Hello, everybody. It's Carolyn Vandyken, and I'm here with Susan Clinton and Joletta Belton at the Genius PT Project, and this is our 6th project that we're working on. We're going to talk in the next couple of months about peer support in pain care and how can peers support rehabilitation specifically. And to lead us on this discussion, of course, is Joletta Belton, who this is her area of expertise, and we're so excited to delve into this topic. So I'm going to turn it over to you, Joletta.
Well, thank you so much. I'm so excited that we're talking about this over the next couple of months, and that our expert guest is going to be Mary Ling, who is even much more of an expert in this area than I am, because she's been doing peer support groups in Australia for a few years now, with a lot of official support too, which is something I think we'll talk about today, and the differences between peer support that might just happen in an online environment and not be facilitated in a meaningful way, and then peer support that is supported by healthcare professionals or health systems, and the differences between those two things. As you both know, I kind of fell into peer support just based on my own experiences living with pain, and finding peer support to be incredibly helpful. Like, once you learn that you're not alone and other people have experienced the same thing, that in itself can be therapeutic and is a huge relief, because we tend to become really isolated and withdrawn when we're in pain for a long time, and can also start to feel like this is only happening to us, or has only ever happened to us, and that somehow we are messed up or a failure for not getting better. And then to learn that this is actually not that uncommon, that a lot of people live with ongoing pain. A lot of people have struggled with ongoing pain, can be a huge relief, and that relief can be therapeutic. When we reached out to Mary, she shared with us a couple of resources, and one that I really loved because it's very succinct and bringing together some of the research and then some actual practical examples of how peer support has been used around the world, is this report from Peers for Progress. It's called Global Evidence for Peer Support, Humanizing Healthcare. And I loved that subtitle of Humanizing Healthcare, because I think that's one of the strengths that peer support can bring into health systems and into therapeutic plans and pain care. And my big pie in the sky dream would be that peer support becomes an integral part of pain care moving forward.
If we even think, Joletta, about the term patients or clients, it's interesting to think about and remember that they're just people in pain, right? Or persons with pain. And I think even some of the terminology we use around how we describe patients can create a bit of that disconnect that people feel from the social connection in pain, right?
Absolutely. And I think it's become such a part of healthcare that so many people are referred to as their diagnosis, or as the labels that they were given. And we forget then, because then they become that diagnosis rather than becoming that person that is living with that diagnosis. And that happens in all of healthcare, not just in pain. It happens with people who have diabetes or other long-term conditions, where they're diabetics rather than people with diabetes. We're pain patients rather than people living with pain. And that changes the tenor of the conversation and changes the way that we look at these issues, I think.
Do you think that also makes a difference when we think about the naming of these peer support groups, such as the diabetic eating support group or the pelvic pain support group? Because again, does that perpetuate the labels versus people in pain?
I think that that's
with pain.
It even goes even beyond that, I think, too. I think that's an excellent point. For us, when me and my peer, my good friend Beth, started our nonprofit, trying to figure out what we were going to name it, because we didn't want pain to be in the name of the nonprofit either, because we didn't want that to be the focus. We wanted the focus to be on living well, on possibility, on all of those things. So I think we don't know enough about how these labels affect how we interact with these groups, how we interact with each other, and how that affects how we think about things too. I think that's an excellent point. It'd be great if some research was being done out there on that.
Yeah. It's interesting, isn't
Perhaps
it?
Perhaps there is. I just don't know about it yet.
Yeah. We talk about the biopsychosocial approach, And, we're heavy on bio, and we're moving gently more towards psycho, which is great. And I don't mean psycho as in crazy, psychological. But the social arm probably is still the most neglected arm, isn't it? And there's
Absolutely.
not a lot of research being done in the social arm, although we know it's probably as important as the other three arms, or maybe even more.
Absolutely. Absolutely. In talking about that social element, that social aspect, because everyone lives with pain in a social context, within their families, within their communities, if they're still working within their workplace and trying to manage that. Pain is always experienced in that social context, and is always influenced by social contexts as well. And that's why I think peer support can be such a valuable asset to pain care, because it actually brings the social in. And it helps people to feel a sense of connection again, and to feel a sense of community again that they might have lost through this pain experience, where they might have become very disconnected from their community, from the human community in general, from others. And we know, as humans, we're social creatures. We want to be a part of the human community. And I think that's why peer support has been shown to help with some of these things, that it can help. And this is all coming from that Global Evidence for Peer Support report, that Humanizing Healthcare report, that it can help people prevent disease, that it can help people manage chronic diseases, that it can help people cope with stress or emotional and psychological challenges. And I think these three are all so very important in pain care, because peer support can start at any time. It could start in group environments at any time. And perhaps part of that peer support can help people to understand pain differently before it becomes chronic or persistent or ongoing. And then if it does become chronic or ongoing, it can help people manage that chronic pain. And Keith Meldrum talks about it so well all the time, that the stress and the emotional and the psychological challenges that come packaged with pain. It's not just the pain that we feel in our body, it's everything that comes with it. We always have emotions and thoughts and beliefs about pain too, no matter what the duration of that pain might be. Another thing that's really near and dear to me too is that it can engage populations that aren't reached very well by healthcare systems currently. I live in a rural area. We don't have access to a lot of different types of healthcare providers, or the access is pretty limited geographically or quantitatively. Like, we just don't have that many care providers here. That peer support can help fill some of those gaps. And through peer support, that can then become the group that you rely on. Like, if you're in a flare-up, you can reach out to your peers rather than going back into the healthcare system, rather than having to have an appointment to address your concerns, because your peers can help remind you about all of the things that you've learned along the way, and that it can generally be cost effective and often cost saving too.
Is there some hard data to back that up at this point, Joletta, that you know of? Do they present that data in this report?
Yes, they did present some of it, and there is a lot of it is not pain specific. Most of it is not pain specific, though. It's been shown in other areas. Diabetes management is the one that it's been, I think, most reported in. It's also, there's a lot of more research in the peer support literature in like mental or behavioral health, like addiction recovery. Addiction recovery has used peer support, peer mentors, peer coaches for decades. And it's often something that is paid for through health insurance, even here in the US, where everything is so hard to get paid for through health insurance. But those peer mentors and peer coaches can actually be reimbursed through like Medicare and health systems as well, or health insurers as well. So in other areas, this has been done, but it hasn't been done very much in pain. And that's what excites me about being able to bring this into the pain care kind of space. I think, we've only started to understand pain. I mean, it's been decades now, but it's only starting to kind of take hold. And recently, where more people are talking about the complexity of pain and the complexity of managing or treating ongoing pain, that I think the timing is right for starting to explore other ways of treating pain and helping people to manage what could potentially be a long-term condition, and managing the suffering that is associated with that pain, which I think is one of the most important parts. It might not change the quantity or like the number, vast scale of the pain, but it can help with the suffering surrounding that pain, which can be just as beneficial.
And I think that's so important because, like David Butler said, it's not the pain, it's the suffering. But when you were talking earlier about giving people that emotional and psychological support from their peers, because they may have to step out of their current social situation. You talked about jobs, you talked about their family structure, you talked about their environment in which they're living, and all of those different things where it's not that the support isn't being given, it's not known how to give. You know, people don't know how to talk to their family member that's suffering and pain, but the peer group, there might be somebody that they can relate to that can be their lifeline, you know, or I'm just having a bad day.
Yeah.
You know, it's just somebody who can sit in empathy with them a little bit more, and but that, you know, so that they can actually expand their web of support rather than what ends up I think with people with a lot of pain, I don't have any hard, fast numbers to support this, but it seems to me that they're walking tracks. And they try to do, you know, their family tries to help them in the best way they know how, which they don't know really how. Yeah. And, you know, and the workplace may even be perpetuating labels rather than doing the inclusive reintegration. I think we've seen that time and time again in return to work programs where people are kind of almost punished. Like, you only get to work 3 hours a day and you don't get to be back in the job you were doing with the peers that you loved. You have to be over here doing this. You know, and we're watching you,
right?
And we're watching the clock, and we're seeing, you know. So I think that's kind of one of the things that this could be so helpful for people, is just that other person that they can just talk, that's just like me, that really understands what I'm going through, that I can just pick up the phone and call, or I can reach out to in a way that I can't with the other people.
Yeah, that being able to sit with someone that's not judging you, that you don't feel judged by, can be such a powerful thing for all of us.
Yeah.
With whatever struggles that we're going through.
And I wonder in pain as well, if there's just more stigmatization and invalidation compared to, let's say, diabetes, where there's a, you know, sort of more of a physically apparent disease. You know, this invisible pain that people suffer often leads to more of that isolation and stigmatization, right?
Yeah, I think so, because it's so misunderstood, not even just by the general public or people living with pain, but by a lot of healthcare professionals as well. So I think you can get that stigma of it's all in your head, or you brought this on yourself, or you somehow deserve this. And
You're
that
not
can come
working
into play.
hard enough. You're not working hard enough, right?
And that can apply to like both the getting out of pain part or dealing with pain, and then also back at work, like Susan was saying, and some of that judgment you might have from peers that you got along with and loved before all of this happened, that might be, you know, think that you're no longer carrying your weight at work, and that can provide some frustration and tension that didn't exist before, that can be hard to manage as well. I think this quote speaks to all of that too, that people gravitate towards peer support because of its humanizing effect on care. They like how it provides a personal connection, which I think is what you both have been speaking to better understand their health and expand their role in guiding their own care. That personal connection, I think, is invaluable when it comes to peer support. Like Susan was saying, that being able to sit with someone who can just empathize or be compassionate and not judge, where you don't feel like you have to explain yourself, where they just get it because they've been in that position too. I think that then can open up some capacity, because you're no longer defensive. You're no longer trying to explain yourself. It can open up some capacity to take on new information, to learn new things about pain, to see different possibilities and moving forward. I think this quote too, it speaks to one of my favorite quotes that from Bessel van der Kolk in the Body Keeps the Score book, about how in order to get through any type of crisis or trauma, that we need to make sense of our experience and become an agent in our own rescue. And I think that the one has to kind of precede the latter, but that peer support can help us to make sense of that experience because you're learning from others who've had a similar experience. And then that helps you to become an agent in your own rescue or guide your own care too.
Right. I wonder, Joletta, if you could comment, as I'm just thinking about all of this, around your own story a little bit and how you've told your story many times around how learning about pain and pain science really was the pivoting point where you started to understand what was happening to you and how you might be able to start to change that. And I know that part of what you currently do is, as well, is from a peer support perspective, teach your peers about pain and pain biology and pain science. Do you think that that can be maybe a more effective way for patients to hear about this information because it is from their peers versus from a healthcare professional who doesn't necessarily understand where they've come from? Would that be more believable, or would there be better buy-in sometimes? What do you think?
I absolutely think so. And I think part of it is removing that barrier, like that hierarchy, that even for clinicians who don't want to maintain that hierarchy, it still exists within our systems and within our way that we think about healthcare, where I come in for you to fix my broken body kind of thing. That by being with peers, it's all relational and on that same level. And I think that makes the conversation a little bit different. That it's no longer I'm educating you about a thing. It's we're having a conversation about the shared experience that we have.
Right.
And then that can just open up different ways of taking in information and talking about information that it might not be so threatening. Like it might not be so. I think we often feel blamed when we're told these things, that we've somehow brought this on ourselves. You know, like when we first learn about the science, that I've done this to myself. That it can that message can be very different when it's coming from a peer instead. I know one of the slides speaks. Let me see what this.
So do you think? So in that sense, do you think the peer-to-peer part is more empowering for each of the individuals that are part of it, because it's not there? I love the way you said that it's not about trying to explain a thing or defend a thing that's going on with me. It's just about actually that shared experience, that shared story. You know, that I think there's a great quote about in the telling of your story actually becomes part of the person's life. So that there is that shared experience. And I'm just wondering about empowerment there, how important that must be for somebody, maybe for the first time, to really feel like they've told their story, but maybe not in this way. This is another way of telling the story again. And they gain much more insight again from this new kind of venue to tell their story, rather than in the healthcare system telling their story or their family system. But this is this shared experience. I'm finding that fascinating.
Yeah, and I think often when we're telling our story to a healthcare provider, we tell it in the terms that we think the healthcare provider expects to hear it. So we talk about symptoms, we talk about, you know, the questions that we're typically asked in a healthcare appointment, rather than actually just telling the story. And that perhaps with peers who we don't have that same expectation of, that they're not looking for our symptoms or a pain scale score or any of those types of things, that maybe we frame our story a little bit differently. We're telling it through a different lens, because now this is just a peer, a potential friend. And not someone who's trying to fix us, not someone who we're seeking a fix from. It's just someone to share an experience with. And I think that definitely changes how that conversation takes place. So I think that peer support is valuable on so many levels, because those informal peers, it doesn't have to be a formal peer group, can be incredibly beneficial for people too, just to have that outlet of someone that they can talk to who they feel like is not judging them. And then Arthur Frank, in The Wounded Storyteller, he always talks about how that it's in the telling of the story that we start to make our own connections and can start to, you know, give meaning to our experiences and start to make sense of what's happening. And we don't have that time all the time in a healthcare setting, in a clinical appointment. to be able to tell that story. And he talks about how when you repeat that story over and over again, it's because there's things that you still need to work through, that you're repeating it because there's still things within there that you haven't made sense of. And so you still need to work through them. With peers, you're given much more opportunity to be able to tell that story and work through it than you can in a 15-minute consultation or a 30-minute, appointment. And so that's why I think it could be such a huge, I think those informal groups are really important, but that having something that's supported by the healthcare system as well and facilitated by the healthcare system, and where it becomes an integral part of care, or at least a choice for people to have, can be really beneficial, because then those hard things to do in a traditional kind of appointment can be done in that setting and also be a part of the health system. And that's why I shared this quote too, with one foot in the community, the people living with pain, and the other in the health system, because they've been trained by the health system to facilitate groups, or they co-created this program with the healthcare system. Peer supporters can advance the system's goals, improving clinical outcomes, increasing efficiency, reducing hospitalizations or healthcare utilization, while remaining oriented to the needs of the community and individuals. So that to me is the best of both worlds, where it's supported by local healthcare professionals and the local healthcare system and insurers and the payers, but also developed by and for and with the peers and the members of the community that this is for. Because every community is going to look a little bit different. What we do here in rural Colorado is going to look different than what is done in New York City, is going to look different than what's done in the South, because within different communities within all of those areas, because people are different. Mm-hmm. Communities are different. Access to resources are different. What people want to do or what they would want that to look like is going to be different. So I think that having both the healthcare system and having the peers involved, where there is that one foot on both sides, is where we can see the greatest benefit, or maybe not the greatest benefit, but a benefit mm-hmm. that can then support all of the other things that we're doing as well.
So it's really making an argument, isn't it, for an organizational structure. Like, this isn't just a casual sort of process. It really is quite organizational, that what happens in the peer support groups has some structure to it, it sounds like, has probably a very, sort of specific purpose, but that, again, the people living with pain may relate to that peer support group in a different way than they do the healthcare professional. And so they're going to hear that information. So again, the training of that peer support group and ensuring that it's providing a quality service and the type of information and support that you also want to see from a healthcare perspective, that's also really important. So how does that get done? Is there any kind of blueprint for that, or?
There are actually blueprints. So I've had the good fortune of interacting with our what they're called practice-based research networks here in Colorado. They're also called like community-based research networks or community-based, but it's generally done in primary care. So it's primary care working with members of the community to address a health topic that's important to that community. So our local one, Snowcap, that I've interacted with a couple times, have done actually a thing for chronic pain. They've done things for diabetes, but it's bringing in members of the community, working with healthcare professionals to create programs or materials for the community in regards to those things. And they use here what they call a boot camp translation. And it's a developed process to bring the community members in with the healthcare professionals and come up with materials or a program or whatever it might be. So there are existing resources out there for how to do this. Co-creation and co-production, which we've talked about a couple times in other talks as well, is another way to do that too. And there's within co-production or co-creation, there's lots of resources out there. Dermot Denani, who is in the UK, he's done a lot of co-production stuff, and he and Gemma Pierce, who has some excellent YouTube videos out there on co-creation, and we're still going to be presenting in the Lived Experience Center at the World Congress, if that goes on next year, on co-creation. So it's become a thing that's much more prominent within pain care, but is still relatively new to pain care. But there are ways of doing that, of bringing, and it's also like called like community-driven healthcare in other areas too. So there's lots of names or umbrellas that this falls under. But it's about bringing those community members, the people who are living with that condition together, with healthcare professionals to create together a program. When I spoke at the Tree of Healing conference in Spokane, which was put on by the Kalispel tribe of Indians, they're doing amazing things within their community that combine kind of the traditional Western biomedical model with their culturally relevant and important healing rituals that they have within their tribe. But they also said there too, though, if you know one tribe, you know one tribe. It's not like what they're doing within their community is going to apply to all tribes in North America or around the world. So that's why I think it's so important to be done at a community level. I think it's really hard to just create a program that can then be used across the country or across the world. Like, I think that a lot has to be driven within communities to actually meet the needs of those people. But it doesn't, and that community can be a local geographic one, or it could be around, a specific thing, like women living with pelvic pain, or men living with pelvic pain, people living with pelvic pain. It can be a lot of different things because it can be done virtually too.
So it sounds like the medical community has been much more forward thinking in this regard and have probably done a better job of starting to develop some of these programs, where physical medicine and rehab sort of with pain, not so much. We're a bit behind the 8 ball, it sounds like.
Yeah, just in pain in general, even within the medical community, pain in general is not something that these approaches have been used for very often. Snowcap they did a pain thing with their community, and they created this pain, they called it a roadmap, and it was beautiful. Like the things that people come up with are really pretty remarkable. And I think we don't put enough into that. We don't put enough trust into the community members and the people living with these experiences.
Yep, and again, they're the ones who know what they need the most.
Yeah, and I love that in this report they framed it as person-centered principles, because I think that applies to so much more than just peer support. It applies to how we're all trying to do pain care differently now, and making it more person-centered, or healthcare, not just pain care, but healthcare in general. And the 4 key functions that they identified in this report were the assistance and daily management. And that's like actually learning from your peers skills and strategies to manage your life with whatever condition it is that you're living with. So if it's arthritis, if it's just, chronic pain, if it's pelvic pain, whatever it might be, whatever your healthcare provider is saying, these are the good things for you to do. There's not often enough out there on how to actually do that in your lived life. Like, how do I actually integrate these things into my life? And learning how others have done that can be hugely beneficial. Like other people who, like if it's having children or still working full time, whatever it is that you're trying to manage around, learning from other people in a similar situation can be really valuable. The social and emotional support, which is, I think that is one of the biggest things, and that literally just knowing that you are not alone in this, that you are not the only person who has experienced this, that you're not crazy, that you're not making it all up, that this is really difficult and challenging, and that there is also hope, I think, can be provided by peers better than anybody else, because they know, they've been there, they've been through it. And then also linking to clinical and community resources is important too. And they had highlighted in one of them that people actually being reminded when they should go seek help from their healthcare professional, when they should go see a doctor, when things are, if they've changed, if they're different, that maybe they should check in with their primary care physician or their physical therapist or whoever it might be. And then also linking to other resources as well that might not have anything to do with pain, but might help with pain. Art classes, personal fitness classes, whatever it might be. And then just that it's ongoing, that peer support group is always there. It's always something that you can tap into, and you know, you're not going to be abandoned by them because you lost your insurance or whatever the case might be.
Yeah.
And then we'll go, I laid out, I did way more words in this presentation than I normally do, but I thought they were important words in those person-centered principles. And I think we've touched upon all of these, but it's about, you know, the individuality of people in terms of their lives and their goals, and how, like, great information that you get from your healthcare professionals, from your PT on exercise or sleep or diet or whatever it might be, how you actually apply that in your life to help you achieve your goals. I think peers can really help with. Providing choices, just having choices is a general principle of person-centered care in general, and that it's collaborative, not prescriptive, that this is something that is co-created, co-produced, not just the program itself that is where peers engage, but also within the groups themselves, that peers aren't just telling other peers what to do, that it's more of a collaborative process.
Right.
And that value, I think, in peerness is that it's non-hierarchical and it's reciprocal, that it's people helping each other, not just me helping you or you helping me. We're helping each other.
People don't want to always be on the receiving end of help. They also want to feel like they're contributing, right? And I think often in pain care, if they're always receiving help and not reciprocating some sort of delivering of assistance, that can lead to a loss of autonomy as well, I think, can it?
Yeah, and being able to help others can give you a sense of purpose and meaning. And I know for me, when I started volunteering, it was so good for me. It wasn't good for I'm sure it was still good for the people I was volunteering for and with, but I got so much more out of volunteering than I ever expected. Yeah. And it's because you're focused then on someone else. Yeah. You know, you're not focused on yourself, and that can be huge. Yeah. And then, this is something we've talked about in every single one of our projects together, I think, is sense-making, helping people to make sense of their experience. And peers and peer stories can really help with that. And that's why I think we need to utilize that more, because understanding pain through someone else's story, and then also being given some hope through someone else's story, can be powerful. And then it's also not so confrontational, like this is all about me. It's learning from other people's experiences as well. And then being able to take those bits that are relevant to you and help it make sense and fit in with your life. It could also provide a sense of security in reducing the insecurity that people so often feel in health and healthcare, which is, I think, is especially true for people who've been in the system for a long time and still haven't been able to make sense of their experience and don't know the way forward. Like the people who are still looking for the holy grail, the fix, the one thing. And that can make you start to doubt yourself and doubt your own worth, doubt your own sanity. So I think providing some security around that is important. That it's community oriented, as we've talked about. This is another big one, and I have a slide at the very end to talk about ethic a little bit, but teaching practical skills when necessary, like actual practical skills, like how do you actually do this, and practicing that is something that peers can help other peers with. And those peers might have some solutions that healthcare providers will never come up with.
Absolutely.
Absolutely. That I would never come up with. Because they've figured out how to deal with these difficult things. And then empowering people and building their self-efficacy, which is another common theme throughout all of our talks. So these things I actually think don't just apply to peer support, even though they're in that peer support report. I think they apply to what we're trying to achieve in pain care in general.
These should be our basic goals, really, right? In interventions.
That's why I wanted to put all the words.
Right. How to make sense of what's going on, how to feel safe, how to be part of a community, how to be an instructor as well as a receiver, and how to be, and through all that you get the empowering, which I think is what we're after here more than anything else, is that we were talking about earlier, just that sense of empowerment that maybe my words help somebody else, but I am important enough that I can actually talk about what I think and what I need and maybe how I figured it out. And people are gonna, like it's being received, rather than just, well, okay, that's great that you figured that out, but here's what you need to do.
Right.
Which is what I think we do quite a bit. And I think it's great to because this is the chance for them to be able to, in yet another setting, so the complexity around their healing improves too, because it's not the linear path or the back and forth path with the healthcare provider, but it's now so much more social community, like you, Carolyn, you were saying, that social arm. People forget about, what does that social arm mean? What is that social piece? And this is it right there. This is, people want to, even the definitions for disability from the WHO has the, the final piece, which is what are they lost in their social, in the bigger scheme of things in their social environment, and how they participate not only in family, but in their community and in the world. And this is it right here.
Yeah, I love that. And talking about that community and their place in the world, I love that line too, that it's not leaving individuals to struggle with complex and important things on their own. Like, they're not just sent home with a packet or a pamphlet or an exercise plan. Like, they have now a community. They're a part of something to help them get through these difficult and complex things. I think that's so, so valuable, and that we're finally coming around to see the importance of those social elements. I thought this was an important quote too, because I think it's important to recognize that peer support is an and. It's not a replacement for, it's an and. So it does not compete with or replace the role of others, like healthcare professionals. Instead, it complements and enhances healthcare delivery to assist people through the emotional, social, and practical assistance necessary to manage the disease and stay healthy.
Right.
So it's a big and.
Yeah.
All capitals and.
Yeah.
It's not an or, it's an and.
Right. Right.
Or, I couldn't think of that word.
Yeah. And I like it when there's and in the definition. It's like, it's not that the healthcare is enough, and it's not that the peer support is enough. And means they both are necessary, right?
Yeah.
So I like that.
And that's why I think it's so important to have things in place where it is co-created on both sides, so that people are getting good, sound, science-based information within these groups, but the structure and all of that is co-created between the two.
Yeah.
So this was just my summary of what successful peer support is. That it's based in the community, and that community can be defined in many different ways. That it's co-created, that it's not just something that I developed this for you to implement. It's co-created, that it's compassionate, that I think compassion is, like we've talked with Shelley, is the place to start all of this from.
Right.
I think that it's more conversational rather than didactic is really important too, and that it's culturally tailored. Those were the big takeaways for me, and I liked the all C's. Because almost even all COs except for the
right. Yes.
And without any training or trying to achieve this, I did want to talk a little bit about EPIC, if that's okay.
Yeah, please do.
So this is me and Beth, and this is us out skiing and snowboarding. The first year that we met, I believe. So that picture was taken before we started the nonprofit. And my co-founder, Beth, is paraplegic, and she has chronic neuropathic pain. And we started talking about pain. That was how I was introduced to her, actually. Her development coach knew that I was in this pain space and wanted me to talk to her. And as I was telling her things that I had learned and things that I did for my own pain, she kept saying, why hasn't anyone told me this before? And when I was in school and when I learned all of the pain science stuff, like you mentioned, Carolyn, and it changed my life, my thought was, why hasn't anyone told me this stuff before? So we wanted to come up with a way to tell people this stuff. So we started to do retreats for women and first responders. So this is the space. that we do the
Beautiful.
retreats in. Yeah, it's gorgeous.
Wow.
And I think that that's a really important part
Mm-hmm.
too. So it was created by the two of us, two women living with pain. So in this space, and I wanted to talk about this in terms of the social too, because I think that the space that these things happen in is an important aspect that we don't think about very much either. And not just for peer support, but actual care as well. That one of the women who came to our retreat, who had been living with pain for over 30 years, said that it was intensely relaxing to be there. Our space is, it's not a classroom setup. You can sit on a couch, you can sit in a lounge chair, you can sit in a rocker on the floor, you could stand. So there was multiple ways for people to get comfortable within their own bodies and the ways that they felt most at ease. And then also the environment of, and I think this is one of the values of peer support, where you don't feel like you're being judged, where you don't feel like you have to explain yourself, where you don't feel like anything you say is going to be critiqued or challenged in some way. And she just said it was intensely relaxing. And to me, that was the most, that was the best thing that could be said. And I think that when you get into that relaxed space, that opens up the capacity to be able to learn and take on new information and to see things from a different perspective. So I think that that is a really important part of our retreats. And that supportive, non-judgmental environment, and that it's a peaceful setting. Because we've tried to do workshops in traditional classrooms with the fluorescent lighting and everyone's in chairs behind desks. It never goes as well as when we're in a space with natural light and people can get comfortable. And then it's experiential. We don't just talk about skills and we don't talk about pain. Like everyone shares their stories. Any bit of science or biology that we share it through the lens of the stories of the people who are in the room. And we practice the skills throughout the sessions. We actually do the things. And everything is story-based. It's not a didactic, science lesson. Everything is based in story, and it's more experiential. And we, like I said, we started this without having any idea what we were doing, but it was driven by our desire to get people better information in a different format. And I think that what we did has fallen into all of those categories that report had. And I think that speaks to that there's something to it.
There's some validity to this. Yes.
And that if you just organically come to these things, and then it is supported by the research in, diabetes and, AIDS care, and there's a couple of different stronger peer support research fields than in pain. And I love that we're going to hear from Mary too, who has started a peer support group, but hers is much different. And we'll get to see from a totally different perspective how she created her peer support network and what that looks like now. Now they have multiple kind of groups. I think there's 5 groups now or something like that we'll be able to learn from some of the lessons learned for her as well. And for us, what we thought was going to happen in our retreats is not what happened at all. So I think it's important to also go in with some humility, and that your great ideas, when actually implemented, are not great ideas. But I think having that flexibility, we went in knowing that we didn't know what we were doing, and we let everyone know that we didn't know what we were doing. It was very organic, and then came to be co-created with that first group that we have as to what this can look like. Because it was much less sciencey than I thought that it was going to be. It was much more conversational and learning from each other and validating and hearing and seeing one another. And I think that's actually what the greatest value of our retreats has been, is some of those practical skills where people can learn to calm stuff down, but also just knowing they're not alone and being heard and validated and seen and supported, I think is the greatest value.
Just amazing. I, as a clinician and as someone who loves evidence-based and sort of science, I love the fact that the information that was being shared in this group and co-created still had that scientific basis to it. And I think that is really important in support groups and peer support, because we do see a lot of support groups and peer support that are really well-intentioned, but don't necessarily share or co-create information based on the best science available. So I think that's a really important component, and really hold you in high regard, Joletta, for doing that in your peer support groups.
And I think that even though, so we created a massive curriculum for our retreat, and we thought we were going to get to all of it. That's the funny part. And looking back now, is that we actually thought we were going to touch upon everything we put in there.
Yeah,
it was never going to happen because it's massive. But I think the fact that we had that knowledge base to pull from, the group itself can be more organic. Because whatever direction it goes, we have a very sound evidence base behind what we're talking about. And we talk about the science, but just not in a direct kind of way. We do it through when we're doing the practical skills in movement, in mindfulness, in creativity. We talk about why those things are valuable for pain and how it affects our biology and our physiology. Like stress biology is actually the bit of science we probably talk about the most, because everyone can relate to that. And it's parallel with pain. But I think that one of the ways that peer support has failed in a lot of the areas that it has, there's some research that has been published where they don't think that peer support is a good idea, but then when you actually read it, the way that it was set up, they were set up for failure. Where it was a program that was developed by the research team and then given to the peer leader, an hour before the meeting was to go, with no training. And they're just reading from a manual. That type of peer support is never going to work. Because they're not familiar with the material. They weren't a part of creating so that's just putting people in a terrible position. So I think that co-creation part's important.
Very much like the very original back pain educational formats were laid out in the 80s. These curriculums that you followed, send them to back school. And in back school, they learn what back pain is. They learn all the various pathomechanical kinds of causes. And then they learn not to bend their back and not to twist. And it was all very, like curriculum driven, like this is the program.
And you can't veer from it.
Program. So you lose the magic of what you just talked about in this thing, which is the thrust of the program comes from the client's stories. From the people's stories. And then, if we want to talk about that more, we've got some stuff that's got some great evidence behind it. Like, well, this is why every time you get upset, your pain level goes up. Gosh, don't you hate that? I hate that when that happens. I never, and then somebody sits in the back of the room and goes, I never even thought about that. I had, until I just sat here and thought about that. That's exactly what happens. Everybody gets a piece of it, but now the story is being really driven, in a much more community-based way rather than a top-down.
I mean, one of my favorite stories when we talk about like the science of pain a little bit, or how stress affects pain, is one of the experiences I had going to see It Too, or it might have been when It first came back out in the movie theaters, and there was a loud talker in front of me who was driving me absolutely crazy, and my pain went through the roof. And it was all because of this loud talker man in the movie theater. So I tell that story, I'm like, he was my pain. He was my pain embodied in this loud talker in the movie. But everyone can relate to that, like this person that was like irritating them so much, and either their stress went up or their pain went up, their anxiety went up, but they can see how that happens. And then like, I can't change that person, but I can do things to calm myself down. I was doing little things, like I put my leg up just so I physically couldn't see him anymore.
You could hear him. You want to do this.
I shushed him. I was like a old librarian, like, shh.
Like a Jerry Seinfeld
Right.
TV show. It's the shusher.
Hilarious.
But
So
people can relate to that. Like,
Yeah.
the
yeah,
loud
exactly.
talker in
Yeah.
the movie theater made my
Yeah.
pain go up.
absolutely.
But all of a sudden they're around people who are laughing with them or talking or sharing the experience with them. And they're not just sitting there rolling their eyes or going, okay, well, let's get to the reason what you need to do about making your pain go away.
Right.
You know, it's more like, kind of like, okay, so this is a thing. I'm not alone in thinking that, you know, when I hear a voice like this, it just, my pain levels just go through the roof.
Right.
You know?
Well, and it's much more relatable than just saying stress makes your pain go up. That's meaningless to people.
Yeah, absolutely. But we'll remember the shush story, right? Remember that shush story? So let's wrap up. This has been a great discussion. Just thanks so much, Joletta, for leading us and for really opening up our eyes to the value of peer support. And I think the thing that I really I'm going to move forward and take away from this is this idea of co-creation, which is, I think, the message you really wanted to get towards or get out towards us at this point. And I guess it goes in both directions. We've talked about the healthcare professional sort of didactically giving sort of peer support lessons like the back school back in the 80s. And then the other sort of piece is the sufferer, the people in pain who create their support group, but maybe without that sort of medical knowledge as well, that really we need to bring these communities together, the knowledge of the medical community and the knowledge of the people in pain, and co-create the support that is not just an optional thing, but it's a very important thing. So putting that and back in, it's healthcare and peer support in persistent pain, which is a difficult area that worldwide we're all struggling with.
Definitely. I want to jump up and down and say, yes.
Yay! We'll just say amen, sister, and leave it at that. All right. So thanks, everybody. That was a great discussion. I hope that everybody who's listening enjoyed it as well. And we will come back in a couple weeks' time to have a discussion with the three of us with Mary Wing. We're thrilled to have her join us. And we will set a date for June. And we'll let you know what that date is for sure at the next session, where you can come on and join us with Mary and ask Mary all kinds of questions about peer support and how to bring peer support to your community of people in pain. Thanks again, and we'll talk to you soon.